Hello, everybody. Thank you all for being here today. I'm really excited about this session because we're talking about something that most practices don't think about strategically until it starts to impact revenue or operations, and that's credentialing. Traditionally, credentialing has been seen as a back office task, as something administrative, something you complete and move on from. But what we're seeing now across practices of all sizes is that credentialing is actually much more than that. It directly affects when providers can start seeing patients, when you can bill, how your revenue flows, and how patients access care. So today's session, why credentialing isn't administrative anymore, its healthcare infrastructure, is really about shifting that perspective. We're going to walk through where credentialing fits in your overall operations, where things tend to break down, and what what it actually costs you, not just in terms of revenue, but also time and patient access. And then we'll spend some time on what the best practices look like today, how organizations are starting to think about credentialing as a system, not just a task. I'm really pleased to have Olga Khabinskay with us today. She brings over 25 years of experience in revenue cycle and has worked closely with organizations on everything from payer enrollment to reducing denials and improving collections. So you'll be hearing very practical, real world insights. I just wanted to add this particular webinar is also has a Slack channel associated with it in our Charm Health Square Slack channel, especially for physicians. And all of you who are Charm CHS members are welcome to continue the conversation there. Olga is there. She can specifically answer your questions one-on-one and be able to you can ask your questions there and she can respond to you there as well. You'll have to, if you have any trouble with Charm Health Square, please go ahead and send us a quick help using the support email and we can answer any of your questions. With that, I'd like to go ahead and get started with with Olga, and over to you, Olga. Thanks so much.
Thank you so much, Ranjani. Thank you for everyone for joining us today. Hopefully, we're going to have a nice conversation and I can go into details of credentialing process. I know we have mix of participants on the call, maybe somebody who is already in practice, maybe somebody who is starting out a business in medicine for the first time, or somebody just kind of in between out of network and thinking of going in network. There's a lot of things that we're going to cover today, right? Anything that you wish to know more or consultation or any kind of clarification, again, Slack community is the place for these messages. So look forward to answering that. Let's get started. So first topic is the why we are meeting, why we're having this conversation, right? Well, one of the things that healthcare is really shifting, it's changing a lot, and it's actually doing it pretty fast. Just recently, the telehealth was extended to the end of 2027. So it gives a lot of providers of different specialty an opportunity to consider looking in becoming a participating provider, looking at healthcare by providing these additional services. So we're seeing more and more physicians moving into independent practices because of changes in the regulations, the flexibility, the fee schedule changes, the migration of plans, right? So the complexity increases, of course, when you work with payers. So this is an opportunity for us to have a conversation. Is it worthwhile for you to step into the insurance world, right? What's available there? How does it look, right? Because all of this, something that used to be considered administrative, we realize that credentialing is no longer just paperwork. It's really part of infrastructure of any practice. And when I say a practice, it could be an urgent care, it could be an ambulatory surgical center, it could be an article clinic, any type of business in medicine that provides services, sees patients and wants to get reimbursed, right? And that reimbursement comes from a payer, it becomes an administrative burden to do credentialing. So it's part of the teamwork. It's no longer just an outside on its own, credentialing process. So because it's a core, and because it evaluates the practice, how it operates, how do you get paid, and how you grow, this is the reason why strategic infrastructure and understanding of credentialing becomes vital. So this is why we are having this conversation. What is this webinar is about? It's really designed for physicians, non-physicians, anybody who is in the medical business, who are the decision point of making a credentialing decision, whether you are in starting a new practice, right? Could be a new tax ID, and I'll go into details what that means. Could be being partner of another practice. If you're currently out of network because you're a specialist or you have never looked at credentialing as an option to see more patients, we'll talk about this opportunity being out of network. If you're considering joining insurances for the first time under your NPI, this is the webinar for you. And if you're evaluating different practice models for yourself, maybe you are a multi-state provider with multiple licenses and each state you have own setup, we're going to help you make an informative decision after this webinar because that's exactly what the goal was. Let's keep going. So what is medical credentialing? It's really as a core, credentialing is a process of verifying your qualifications as a provider. We all have a license to practice medicine. That regardless of the specialty, there is a license in place with each state, right? So medical credentialing really verifies your professional documentation, including your education. It verifies your license, it verifies your boards, education and training, your work history, right? Again, when we're talking about all of this, this is all pertaining to your medical background. It looks at your sanctions, potential lawsuits, any kind of background while you work as a hospitalist physician. And of course, your enrollment as a payer. Have you been ever before credentialed with us? What is the current conditions of your credentials? Have you ever been non-renewed? So credentialing determines whether or not you can bill an insurance company, right? Credentialing is a broader term because in some places we often hear of the word credentialing as a CVO, verification process. Therefore, credentialing word in its own became a synonym of the same kind of word when it comes to getting credentialed with insurance company, really getting contracting, getting enrolled, stepping in as an in-network provider. So this is what it really means for you when you hear the word credentialing, right? So let's look at credentialing and revenue cycle, right? So credentialing is kind of like the first step into getting paid, right? Because we are able to get paid from the patients. We are able to get paid from the employers that are sending us the patients if there's an agreement in place for the physicals, but we also can get paid out of the network from the plan without doing any credentialing, and we can become participating provider by going through the process of credentialing and realizing that only through that process we consider to be active and start getting paid from that. So if the step is delayed or something's done incorrectly in the process, right, it affects your financial revenue, right? Claims get denied, insurance billing is not possible to be done, revenue is delayed or lost, depending what's happening with your contract with an insurance company, but impacts your overall practice financial performance. So knowing credentialing flow and how it affects the revenue is very important in maintaining healthy practice and financial freedom and have an ability to have a flow constantly and the referral. So all of that really creates a nice bottom line for you when you become looking into creating your own infrastructure as a practice. Um, where credentialing shows up in your daily workflow. It's a pretty big slide. I'll go slowly in details, but I do want you to see the components of where and how in your daily routine work you're able to work with the terminology credentialing, right? So once you are a credentialing provider, your whole infrastructure of the practice changes compared to out of network or compared to never before accepting any of the insurance companies, right? So your scheduling changes, right? So your providers must be credentialed to be booked, right? That's typically what the outcome is because patients that are booking have an insurance company, insurance plan, and they want to make sure that if they're seeing you as a provider of services, that your reimbursement, the majority of the claim, the invoice, will be covered by the plan, right? Yes, they'll cover the copay, they cover the deductibles, but you want to make sure that the scheduling team, right, the front desk operations team visually understands the participation status of every provider, right? So that the front desk doesn't have any restrictions, right? So you kind of want to make sure the scheduling team and the scheduling platform you're using is set up with those rules, right? The next portion of credentialing in your workflow is the EHR, the patient visits, right? Where everything is kind of stored. In order to be able to see the patient, use the provider, have to check eligibility because If you're not checking eligibility, you're taking a risk of not getting paid or a risk for being liable, some kind of issue with the claim. So you have to check eligibility, and the eligibility itself, you can check regular way, right? Through your clearinghouse, through your EMR vendor, through Charm Health. But what happens is that if the provider's tax ID is not connected to the contract of an insurance company, or the provider NPI is not linked to the tax ID, there might be a disparity between if the provider is actually be eligible to see this patient, right? So that's important to identify as you start your setup of EHR or you start your communication with your front desk about eligibility, right? Because the incorrect setup of that NPI will lead to denial. And that's exactly what you want to avoid, right? So the providers must be linked correctly in the system by insurance status. And when I say status, it means participating provider. I am a PAR provider. That's the common term insurance companies refer to. And then you'll be able to say that I'm able to see these patients. And if you're using outside schedulers like ZocDoc, right? You can have an insurance add-on there to say that I am accepting Aetna, I'm a participating provider. So there's a synchronization between your appointment scheduler and those outside platforms that are usually helpful. How else? Well, then there's a charge entry and a claim submission, the RCM process, right? That also is going to be affected by your credentialing status because to bill, to get paid, you have to be credentialed. So therefore, you have to be an enrolled provider. And if you're not, your claims get denied or they cannot be submitted at all. A simple case of Medicare. It's not an open door policy. You cannot transmit a claim to Medicare unless your NPI is linked to your MAC, which is your local Medicare carrier, and you're able to be identified as a treating provider. So there are instances where it's not even possible to send in the claim, right? So that verification does come up in all these specific areas. And then finally, we get to the final stage of the daily workflow, the billing and the reimbursement. This is where the insurance company receives the claim for your services and wants to make reimbursement, but without credentialing, without having that participation status, it's going to get denied and rejected, which is going to create delayed in your cash flow, and it will affect the overall revenue cycle, right, for your practice, because you might have several patients with the same insurance and your status is non-par, which can result in significant delay and denials of your claims. Let's move to the credentialing payer enrollment because this is also a two key process here, right? We have credentialing and enrollment. Credentialing, as I mentioned, it's verification of provider qualifications, the license, the boards, everything that you pretty much run to the American Medical Society, that report. If you want to know how insurance company does it, by the way, they take your license and your NPI and they run it against AMA. It's a report that identifies your whole summary of educational background that you have completed, including your CEU credits and CME credits. So it's a nice report that kind of summarizes for the insurance company your qualifications as a provider and demonstrates your specialty and other supporting documents, right? And the enrollment process where they actually enroll you as a participating provider, which allows you to later submit claims, receive payments, and stay on board in the insurance network as a participating provider, right? And there are many benefits we're going to talk about being the participating provider, right? Because I want you to really understand the magnitude of opportunities when you become a participating provider. The conversation we'll have down the road in this presentation. The questions many physicians ask, right? They ask their peers. I'm sure you guys talk to one another. Your best friend is a doctor. I'm definitely aware that we communicate in a tight circle and we kind of want to identify a right business process we want to start. So, should I credential with insurance payers? Should I remain out of network? Stay private pay, right? There's no single correct answer. And it's really true. Everything depends, number one, on your specialty. Number two, on the population demographic, the patient population in your community in the area of your office, right? Where are you situated? Is it a commercial, Medicare, Medicaid-based practice? Like, what is your demographics of your population? I'll tell you an interesting thing. We recently were identifying if a client in Suffolk County, New York, had an opportunity to have a practice in a very nice area. And we could not really understand the insurance companies that are present in the area. So we just decided to do a survey. We paid a college student to stand in a supermarket, a very famous supermarket in that area, just take down the names of insurance companies. And we learned dominantly there are only two insurance companies, Aetna and Blue Cross Blue Shield. These were the holders of these insurance companies that were living in the area and most likely be the candidates to go to the cardiology practice that was studying out there. So our goal will be to focus all of our attention around these two plans. So there's always ways to find out, either through a census review to see an opportunity, what are the insurance companies more common in the area? And you can also walk into any practice and say, hey, I'm opening up. I'd just like to know what's more commonly accepted here. Because some plans are very common, but there are some smaller plans or Medicare Advantage plans or Medicaid HMO plans that not common in all areas, right? So the geographic market is important to understand. And of course, your business goals, right? How accessible you're going to be to clients, how many hours you're planning to open. Can you dedicate really 16 hours a week? Because 16 hours a week is considered to be an average operating time for a practice, a primary care and a specialist. So you got to really think, if I'm a hospitalist also, or I'm running another clinic somewhere else, or a medical directorship role somewhere also where I'm dedicated to a certain number of hours, how many hours can I dedicate to my business? And if I want to bring this business into the insurance, then I have to meet the requirements of being open, the hours that I've listed that will be open. So questions come up as we talk about this process. Let's talk a little bit about understanding out of network practice because this is not the credentialing we just mentioned. This is not for you to complete any paperwork. This is not an opportunity for any qualification review. You're not accepting patients within insurance itself. You're not contracting. If the patient wants to come in and they have an insurance company, you are considered out of network provider. You will have a flat fee for that visit and you will take that amount from the patient. You can give them an out of network claim to send out to an insurance company, but your relationship pretty much ends there. If you do pursue to bill out of network because the patient has out of network benefits and you yourself out of network as a provider, then you're going against the deductible, the co-insurance, and all the eligibility issues that come up with benefits management of that patient. That comes up also for some of the insurance companies, mostly commercial, the private line, and some of the Medicare Advantage plans. Out of network practices operate without insurance contracts, but they can still submit claims, right? So you want to understand the difference. You're still able to submit a claim because you're out of network, but you want to claim the out of network opportunity there, that it's sometimes done through negotiation. And most of the specialties that use this opportunity to bill out of network without an insurance contract, psychiatry, right? We're talking about TMS, ketamine therapy, medication management, a lot of different things psychiatry umbrella covers, but typically it's a physician psychiatry. Functional medicine, right? Concierge medicine, aesthetic medicine, certain specialty practices, right? So you got to really understand your particular specialty, what it is capable to do within the insurance company, what limitations the insurance company offers to your specialty, right? And that's how you would kind of tailor your plan if of deciding to stay out of network without a contract or get into network with a contract. So changes of staying out of network, right? There are challenges. Challenges are there because it's more administrative time. It's a triple eligibility check. It's more documentation when it comes to tracking down the benefits. And if you're negotiating with an insurance company back and forth, there's more time added on to the actual payment of the claim, right? So a lot of providers really decide if they're able to handle this administratively in their office. Do they want to hire a company or a team to do it as a service? So there is a lot of challenges involved with that, right? Once you put this burden on your practice, you're kind of limiting yourself in patient access, right? Maybe it's going to take longer to schedule those patients if you're still deciding and dealing with the insurance company in the previous date of service negotiation, right? You're going to reduce the referral load, right? Because when you're out of network without a contract, your information is not displayed in the insurance directory. patients can only find you through your own way of marketing, right? If you are marketing your own in your own community, then they'll be able to find you, right? You're also dealing with out-of-pocket costs, right? You have to bill the patient for the balance, right? So it's something where you have to decide if you have the time and you're willing to go through this process to stay out of network, right? Also, some providers have told me over the years that being a network gives me a source of referrals, right? Because they're able to find me quicker. I'm being referred by other physicians in the community because I'm in network. When I'm out of network, primary cares or other specialists will be hesitant to refer a patient to me because there is a out of network status in my practice, and maybe my patients will not be willing to go into that challenging process of negotiation and meeting the high deductible if there is one. So it's a consideration to be made to evaluate your demand in your local area, right? It's important to do that. Let's look at the benefits of credentialing with payers, again, meaning that we're going into a contract, right? One of the biggest advantages that you get access to a larger patient population, right? By last name, by your last name, or by your specialty in a specific territorial area, I can find the provider and I can, by myself, schedule an appointment because it's a more reliable system. And I'm going to give you an example. If I'm an Aetna member, I'm an Aetna patient, and I'm looking for a urologist, right? Yes, I can call my primary care doctor. I can ask my friends who are they seeing, but I can also go into Aetna.com and use their option, search for provider by specialty, plug in my zip code, and your name will come up because your practice is within my territory, and I'm going to call your practice phone number to schedule an appointment. A lot of individuals who have an insurance do locate their doctors in this type of way. Of course, there are platforms, ZocDoc, and many more that have implemented the rules where it's much easier just by specialty to look up who accepts your insurance, right? Instead of going to the insurance site, you go to someone else's site and just go from the insurance point of view. But this is driving market today because patients want to go in majority of the areas to a participating clinic because they don't want to get billed for out of network negotiations. So access to large population definitely exists when you're credentialed. Inclusion in the payer directory, that's the part where they can find you there, right? They can find the language you speak, the locations you where you at, the hours that you're working, and the specialization, right? If you're pediatric urology or just adult, so you can actually have, broader spectrum of the things that you do and then the uniqueness of your specialty, right? Referrals. So referral now becomes also easier because if I'm a primary care doctor and I need to right away find a nuclear cardiologist because I need to get a PET CT CAT scan done, right? I'm going to just tap into the insurance and quickly find someone locally in the area. So I can refer quicker. Again, increasing populations of referrals into your practice. And it's a more predictive patient volume. You can actually track and analyze how fast you're picking up new patients with insurance companies because of your participation status. So going in network does give you an opportunity to do a lot of beneficial items, not only increasing your patient population, also leveraging the increase of your practice revenue, right? So it's an accelerate practice growth, really what we call when we speak about credentialing. Let's look at the financial risks of credentialing delays, right? Because credentialing is not something that's done overnight. And I cannot not say the fact that when we work with insurance companies, it's challenging. They don't really call back. We always say they're not reliable, as if they don't want it to be part of their network, right? We get frustrated with some of the plans. One of the biggest plans that really causes the frustration sometimes are the biggest national plans, right? The Cigna, the United, the Aetna, those great names, right? Large insurance companies. But unfortunately, even with them, there is a challenging process of getting the participation status for each provider, right? As if they don't want my practice, as if they're doing everything possible not to work with me. That's the feeling we get. So the walk away today is that credentialing is a process, right? It's not an overnight thing. Typically, 90-day process is what we wanted to expect. That's the perfect world. Well, we tend to get into 182. days as well. That means that you cannot see patients yet. You're still being onboarded. There's still something going on. The case has not been finalized. So it's a process that is delaying your opportunity to start welcoming patients into your practice, opening up all the referrals channels, activating your appointment platforms, right? That's a delay that you experience because you're not gaining the money, but you have to pay the rent, right? You have to pay your front desk, you have to pay your clinical team. So there's a lot of things that you have to cover in order to be able to retain the revenue you invested, right? So, and every time there's a delay of credentialing, you are delaying your start day, right? Sometimes I hear we're going to have an open door event. When do we start doing this? You should start doing in your last 30 days of credentialing, right? When you're already, let's say today's March 19th. So we are March 18th, sorry. We are approaching April 1st. We should have all our contracts in place. April 1st will be our opening ceremony. So a lot of things really navigate around that credentialing because you want to be able to start seeing patients the first day as soon as your contracts are effective with an insurance company, right? Also, the financial risks that you're facing. Let's say something happened to your contract, right? You were credentialed, you were seeing patients, you were par, and you all of a sudden started seeing denials, right? So there's something wrong. It's not a technical issue. Your claims are getting through. It's something within the system of the insurance company. There's something missing, maybe expired documents that you have not submitted. Maybe they didn't do verification on you, but there is a certain issue in your contract which is leading to denials of claims, right? So that's your financial risk. Now you're in a bigger pickle, I would put it this way, because you're considered a non-credential provider and you're actively seeing patients, right? And ability for you to build back, right? A lot of doctors think, well, I'm starting credentialing right now, which means I can start seeing patients and hold the billing, right? No, no, no. You cannot do that. Only one plan, the federal Medicare, the Medicare plan allows you to will give you a 30-day window when you can request an insurance company to retroactively make you effective at most 30 days. But every other insurance company will give you a future effective date. That means your plan to open the doors to start seeing patient on the same at the same time as you credentialing is not a good plan. So we have to always consider what are the risks of credentialing process so that I can avoid them and start when I am officially in the network. Revenue impact examples, right? We want to talk a little bit about the days because I want you to understand the leakage of revenue you will experience if this does affect you, right? This credentialing process delay. So I'm giving you a couple scenarios here. The first scenario is that new provider starting a practice. You're super excited. You got your loan or you're starting out a practice. You have your place. Everything is ready, right? You should be seeing about 20 patients a day. That's your plan. Your average reimbursement is $120 per visit and you're working per day per month about 20 days, right? So your monthly revenue for the first 20 patients you're going to see times 20 days is 48,000, right? Then, if you are not credentialed with that deadline, you're losing revenue. So every 30 days of your delay, if you're 90 days delay, you're losing 144,000. So again, I'm just leading to not for you not to see patients while you're credentialing because those are not actual revenue. You will be losing out. And the 120 delay leads to 192,000. So whether you're starting the practice or hiring a doctor into your practice that has not been credentialed, do not allow them to see patients yet. They have to be credentialed first, right? That's kind of the rule here because otherwise you're going to get not only the delay, but you're going to have a loss of revenue. You will work for free. And credentialing delays you can see in a total practice or per provider, depending how you're set up as a clinic. Can you see patients before credentialing? I already answered this as a general way, but I will say that in some cases, yes, but with some important limitations, right? So you're not in network yet. So claims can be denied, rejected, non-paid, right? So make sure that if you are having those results right now in your claims, that means there's something wrong with your status, right? Unless there's a denial reason that states something else based on the clinical necessity or missing medical necessity, you will see this. But missing credentialing does lead to denials, right? So what can you do? You can see patients for cash while you are fixing your contract, right? Because you're not in network, so you're not charging the insurance company, right? You're working directly under a special patient agreement with the patient. By the way, you will need to set up those agreements. As soon as you switch from billing insurance company into private pay with the same patient, please make sure you have a financial agreement with the patient agreeing on all the services that you're going to provide out of network. Okay. You're going to have a little bit of a delay of scheduling insurance patients. So, for example, if there's a gap and they have a whole appointment for the month, you're going to have to take that appointment list and shift the patients to the next month or the point of being when you're going to get credentials. So there's a little bit of administrative work that needs to be done to manage the things while you are out of network, right? Question that always comes up into to our company is that can you bill later or hold the claims, right? We always say seeing patients before credentialing is a high risk. It's really difficult to deal with it. It's a disconnect between the patient and you. And then unless you're really straightforward and there's transparency and a contract in place, that patient understands the fact that you're currently out of network and that you're agreeing for the patient to reimburse you for the services, right? So it's important to kind of cover those items here. There is no such status to put claims on hold unless, and there are situations. That's why I answered these questions, yes, but with important limitations. You could be experiencing an issue with your contract as a participating provider. Maybe there is a problem with loading into a new data system. Sometimes that happens, right? Within the big insurance company, right? Sometimes insurance companies change the platforms they work in. So there could be a possibility that you're going to open something called special claims project that's going to reprocess the claims, right? But literally, you cannot see these patients and hold the billing. You have to figure it out. As of this day, this is the relationship we're going to have with these patients while my contract is out of network. You have to have a solution. Insurance companies love to deny, they love to take money back, and they will do everything possible to make sure that they will not pay the claim, right? So you want to make sure there is a process in place between you and the patient protecting your revenue. What happens if the credentialing is delayed? Now, this is the case where either you are fixing your credentialing or you're going in for the first time, let's say to Aetna, and you're going through the process, right? So I split it into several categories so you can see an actual reasoning of the delay in each area. So operational impact, right? It delays the onboarding date of the provider, right? So if you made a commitment, you hired the physician has a start date. If the credentialing is not a place, they can't start, right? There's no incident to physician, right? This is not a nurse practitioner working on the physician. This is a different scenario. So there are state regulations based on scope of practice that allows you to kind of understand what can I do in this situation. So we would prefer and would recommend that you would hire a physician with an extended effective date to start. So I finish credentialing process first, gain the effective date, look at it, and then from there project an estimate time frame for them before they can start, right? Unless you're fully Medicare practice or 70% Medicare practice, and you can allocate the other 30% to another physician with all the plans, then you can focus on hiring these providers to see Medicare patients because Medicare credentialing can backdate it to 30 days. So you're going to be limiting schedule for insurance patients for those doctors that you hired on board, or even for yourself if you're not yet credentialed, right? You're underutilizing staff and resources because you are paying salary, you're paying all the bills, but you're not getting the revenue in because of your credentialing delay. Something to think about, right? Uh, that's why sometimes when you build a practice, you would want to maybe sublease spaces to different providers where they can independently manage that space and you can have a little bit of a rent coverage or the front desk operation coverage from these leases. Any kind of delay will also lead to change in the demographics of your practice, right? You might not be able to onboard new providers, or maybe you wanted to hire four NPs to work with your MD. That's not going to happen now because that MD cannot even see patients because they're not credentialed yet, right? Patient access limitations, right? If you're not listed in the insurance, they can't find you, which reduces referrals, right? You're going to have limited patient access to care. If you have patients that were under your care, but you had an issue with your contract, you're going to have to lose those patients or set up an agreement. And that's going to drop your patient volume, right? What financial impact you could have? You can have a delay or loss of revenue, right? If you're billing, if you decided to do billing and the claims get denied, you're losing that revenue. If you're delaying because you're holding claims, which I don't advise you do it, you're again losing the revenue. It's harder to manage claims denials for non-credential providers. So you're again onboarding an additional challenge to your team where they have to fight over for claim by claim for every single provider that's out of network or lost their status because of credentialing, right? So you're disrupting your cash flow and you're increasing your account receivables because now those claims turned into 120, 360 days overdue because the insurance company is processing your contract first and then going into your claim processing. So it's a lot of impact financially that you're looking at. Administrative burden, right? You have to rework some things, you have to resubmit, regather, check everything out, right? Adding more time for which you're paying to your staff. Constant follow-ups, we have to continually make relationship with plants. We have to call them. We have to stay on top of these things, right? And it's all have to be done by us, not AI, right? You can have AI do it too, but it's us, the humans, that have to do this work because we need to make sure that we can track it. We have enough evidence to show insurance company it's not our fault because we want to process claims, right? So we are using staff time, we're diverting our staff from doing something important for the practice, maybe growing the practice, maybe calling patients that were not there 3, 6 months before for them to come back to see us. So it's increasing operational expense and stress, right? So my final note was here, credentialing delays impact every part of your practice, not just billing. It's very true. Credentialing and patient access, right? So credentialing directly affects patients' access because they get to see your name in the directory. They get referred to you by another referring provider in network. So this is another concept that you need to understand. The care accessibility expands, continuity of care, right? Insurance company wants you to see in-network doctors. That's what they tell patients. That's when you kind of see an interventional radiologist performing a surgery and anesthesiologist is out of network. The insurance company will target the referring provider, asking for the reason for referring to the anesthesiologist who is non-participating, right? Because they don't want to pay expensive claims. They don't want to pay out-of-network claims. They're higher than the in-network claims, right? So that would lead to you having patient not finding you in the payer directory. Referrals may be limited. Scheduling may be restricted. So there is a great push surrounding us from insurance companies preferring that the providers are going into the network, right? That's why we actually have a lot of stack of these letters from different insurance companies requesting reasoning for you to request an anesthesiologist to be part of a surgery team when they're out of network. Why was that choice made, right? So God have to be a little bit careful for that. So why is credentialing an infrastructure, right? What we started our event with, and we're getting closer. We're halfway in, by the way. So credentialing supports revenue cycle. We just explained that your status as a participating provider directly impacts your bottom line. It directly impacts your reimbursement from insurance companies, the flow of cash, the frequency of submissions. It directly impacts that, right? Compliance requirements, right? You really cannot bill the patient for the balances or the differences unless you have an agreement with the patient, right? You have to understand that there's a gray area between out-of-network billing in-network billing. So you have to figure out what infrastructure you're going to have. Will I credential or I will not have a contract with an insurance company? You want to have a consistent, good relationship with the insurance companies, the payers, right? If you're in a state or a city that has dominant insurance companies, right? You want to establish a relationship with them. You want to know the provider reps, the executive team, and you want to make sure that you follow their specific guidelines, whether it's the Medicaid-based guidelines, Medicare, or the commercial, right? You really want to make sure that you're following them, right? You want to have a provider onboarding process, a smooth process so that you don't rush, that there is no stressful event in the practice when you're hiring new staff to work with your patients to get credentialed, right? And you want to make sure that your network participation is always up to date. I meet clients that are 20 years in business, 30 years in business. They don't have a place where they hold a copy of their contracts from the insurance companies. They don't know their fee schedules. They have no idea the effective date of their contract. So that is a process that you need to also implement inside your practice, right? You need to have a hold of those documents. They're valuable. They're used for negotiation down the road. Common credentialing challenges. So many organizations struggle with manual paperwork, right? We all know this. We are so grateful that electronic EMRs, EHRs have been developed and they are organizing much better the life of a physician, right? But in the credentialing world, manual paperwork still exists. We still have paper applications. Uh, Not all insurance companies, but some still on paper. Like literally, you have to sign with a blue ink pen and mail it in, right? Some insurance companies lost that process, which is amazing, and they are have portals, right? But there is still manual paperwork needs to be done. Some insurance companies have very complex requirements to credential. They want you to have hospital affiliation, or you must be board certified, not board eligible as a provider. They want you to have a covering specialist. Without it, they will deny an application. They do not want you to have more than 10 years of sanctions, right? So you get to know the insurance requirements also when you get your package, right? The package emailed to you when you want to become a provider with an insurance company. There's a checklist and tells you, hi, this is what we're expecting from you as our provider. Please follow this and please provide us all the information, right? Timeline. We talked about the perfect world of 90 days, but that's not the timeline we live in. And not much place we could go to complain because it's still the people we work with. There's a lot of doctors applying. If you just look at the medical school, every May, a medical school, either internationally or in United States locally, releases a graduating class every May, right? So every year there's a cycle of people that are going into residency, leaving residency, wants to do something privately, start their job in the hospital, start working for themselves as well. So it creates a lots of application and the bottleneck of the process of getting into the insurance, which delays the process of credentialing, right? Yes, insurance company implemented AI and it's supposed to help them with processing it quicker. I have not seen a good outcome yet of AI except down coding and everything else that they're coming up couple 2 years already, right? That we're starting to see. But there is a delay because of an enormous amount of providers applying in network with certain plans. So you will see that and experience that. There could be missing documents. I am perfectly aware that there's no class in medical school and there's no training in residency or your post school training that talks about credentialing. I'm completely aware that some of the names that I might have mentioned of the documents you have seen, but you have no idea what they're called. And I'm completely aware of that. But sometimes because of that, right, not knowing, not having it maybe, right, the cultural competence, infection control certificate, like and a lot more of those, right, that sometimes are being mandated to provide with an insurance application to become credentialed. We don't forget to attach them and they delay the process. The application is set back. to give those documents. So those are the challenges here too. And administrative workload. So if I am, and I'll give you a good scenario. If you're trying to cut costs for credentialing in your practice, if you want your manager, your front desk to do everything in the office, something will not get done. It's not possible that your front desk can manage the practice, do billing, do credentialing, see patients, and smile at the end of the day, right? You're going to have somewhere a process that's going to be not performed. So administrative burden, that's what exactly will happen. And there will be delays because of that. So it's very important that you really understand the direction of your business model and hire the people that can help you or properly delegate to the people that you know can get this done. What happens when credentialing goes wrong, right? When we say wrong, it means it wasn't mailed to the wrong place. It means that internally there's something wrong with it. Wrong NPI, wrong tax ID, a typo of a 9 of a 3. The address is wrong, right? Application rejected, right? Delayed by weeks. Incomplete application. Some documents are missing, would be an example, right? Everything that you're going through restarts the application again, restarts again your time, right? And again, creating that gap between realistic start date and what's happening now. Where are we going to get? When we're going to get there, right? So then you have the provider is approved but not linked to the billing system yet, right? I love those status. That means we need to give 2 more weeks until the billing data system sees that from the insurance side. What it really means is that once you get approved, your contract walks towards from the contracting system where they've just loaded you in and said, hey, you're now effective, to the billing system of the insurance where you can now recognize and process your claims. There are two systems, there's a bridge, and you have to take that walk. That's what really it's happening. I don't know why it's not one in one, but that's exactly what is happening here. Other challenges that come our way, right? Missing something from the state. Maybe your license was due for renew, but you missed the mailing and you did not renew your license. The whole world knows about it, by the way. Insurance gets information reported to them by the NDPT. So it becomes very obvious right away. Also, if you lost your state Medicaid because you forgot to revalidate, they're also aware of it and you have a you have a chance of losing your contract with an insurance company. So it's important to know when your revalidations dates are, which is sometimes called recredentialing dates with each insurance company, right? Again, as I said, every insurance company has its own personality, if you can put it this way. And you have to really learn the requirements and the rules of that insurance company so that you can be on top of it and compliant. That's exactly what you want to do because it helps you in billing too down the road with audit and compliance and being a participating provider that can meet all these expectations, right? The cost of inefficient credentialing, right? So if you set the responsibility to somebody in your practice that's not capable to do this, had no experience, or you want to do it on your own because you do not have the income right now to hire a credentialing company, or you are just starting out and you're dedicated to do this to help your family do this, right? Just keep in mind, right? If inefficient credentialing will lead to denial of claims, it would delay the incoming revenue. There's risk of compliance because obviously you're not doing something wrong, right? If you're not participating and you're seeing patients in network, it slows the process of onboarding of any provider that you're hiring. If you're a group and your group is not contracted with an insurance company, you're not able yet to hire those doctors to bring them on board, right? And you're also increasing administrative costs because everybody's working, right? This busy office, but there's nothing coming in from the insurance side for the services that you're performing. Starting a practice, the business model options, right? And I'm going to go a little bit quicker just to kind of maybe speed up a little. We have 10 more slides to go. So, physicians starting a practice today, right? You have a couple options here: traditional insurance-based practice, hybrid practices where you mix up insurance and cash. You're in network with one insurance, but you're out of network with some others, right? So you're mixing up. Concierge practices, we very common known this is an additional membership fee that you can charge your patients. And you can continue being a participating provider with insurance because this is all about accessibility. If you are a member of my practice and you're paying concierge fee, you can have my cell phone number as a doctor. You can call me during any after hours to discuss your needs. I'm always available for you. So it's an additional support if the patient needs it, right? You can have a fully private pay practice. So you have a couple options how you can operate, right? Telemedicine practice, something that mix in ideally what you want to accomplish. So, and each model here has a different credentialing process that we talked about a little bit, right? So, traditional insurance-based practice, you have to credential, you have to follow the rules, you have to wait till you are approved to get paid, right? So there's a flow of things you have to do, right? You can't skip a process. You have to go through the process because that's what the insurance company wants you to do. This is their policy for the doctors that are going into the network for the first time. The hybrid model can play a little bit here because you have an opportunity to catch the revenue. You're not leaking anything yet. You have the cash base and you have the insurance base, right? You can activate cash first and work on your insurance and then slowly shift everyone to the insurance or leave the mixed model. It will be completely up to you. Concierge model, we kind of talked about it. It's not conflicting with your participation status as a credentialing provider, right? You can have predictable revenue from memberships. You can have smaller patients amount. You don't have to have such a large volume of patients in your practice if you also have the concierge benefit to it, right? Which is directly reimbursed by the patient on top of what the insurance company will pay for the visits and everything that you're doing. It's an additional kind of like a bonus, right? But it will take your time, where you'll be committed more to the practice after hours. Private pay practice only model, where you're completely out of network. You are not a contracting provider. You're not following the rules of insurance companies. You're documenting as you want to document, as you learn to document, and you're not sending your records to the insurance company for any review, right? Your payments are coming from the patients or any kind of relationship you built with employer groups for physical screenings, and you can offer flexible pricing. So you have a lot of ways to look at these models depending on your patient pool and your territory, geographical territory. Telemedicine practices is an add-on, right? So if I used to do just face-to-face patients, now with getting new license, if I'm a multi-state license provider, I can kind of discover the idea of telehealth and see if my specialty allows me to do telehealth medicine multi-state while I'm, let's say, situated in New York, but I have a Pennsylvania license. I can activate telehealth capability as well by following HIPAA compliant regulation. So it's an interesting model how it works. It's just for you to define what will be a perfect fit for you. Choosing the right model, again, going back to the questions we started with, right? Who is my patient population? What services will I offer? What is my local market demand? This is actually a very good question. Urgent care became a booming business during COVID, right? And after that, it kind of sunsetted a little bit because we were not as busy. So you're not looking at what local market demands, but what are the needs of my community? What if I don't have an urgent care and we all have to go to the hospital ER? Maybe if I create an urgent care in my area, I can get those referrals from the hospital to my location. So review your area. It's based on demand. What exactly is missing from the operational process of healthcare in your community that you can help with, right? A lot of pediatricians, just to give you a great example, opened by the schools because they want to grab the kids and the families as they finish the school time, come in for follow-ups, come in for shots, right? The location matters. Keep that in mind. How credentialing supports practice growth. Right, we're gonna get an increase in many different variations here, right? So we have more insurances we accept. Our referral partnerships work better, right? Because in-network provider has a responsibility to refer only to in-network specialists. So there's a relationship building there, right? You're gonna have increased patient access, not only from the referring, but also from the provider, from the patients on their own by finding you in the directory. And you can scale your operations. You can actually say, if today I only accept 2 plans, if I add 2 more, that means that I can get more patients in, more exposure, higher revenue. The role of technology, right? I think technology has really changed the way we operate, and insurance companies also using technology that really changes credentialing. So you can do credentialing on your own. You can have a credentialing software. I've heard great things about CrediApp. You can do everything faster with technology. So it's always important to look at technology and see how you can utilize that to get you into the insurance role faster. So there's a lot of processes here, how to centralize the technology to help you, right? We all heard of these portals that insurance company use, right? Each insurance website has a portal that you can log in to work inside the portal, right? But it's not technology. But back in the day, we didn't have these portals and everything was done by mail or fax. So in some way, insurance companies are improving their standards and accessibility to their data set by utilizing this technology. So we definitely can discuss this as an opportunity for you guys when you work with insurance companies, right? Centralizing credentialing system, right? You really need to have a place where all your documents are stored, right? Your Medicare contract, your Medicaid contract, your fee schedules, negotiations, addendums, carved out codes. If you are adding codes that you're going to do because they're not part of your contract, I want you to find a place in a system somewhere in your technology software where you're going to store this information. This is valuable. If you plan to sell the practice, it becomes even more valuable because you're working with original contracts. You can compare rates, you can request same rates. You can deny contract negotiation if the insurance company is not meeting you where you need to be. So I want you to create a place where the credentialing is centralized. It's very important to have access to that information. And if you're on a call today and your practice has been operating for 10, 15, 20 years, I know that you have no idea where those documents are. Request them. Scan them, hold them, attach them, make sure you have them. They'll be valuable for you. Breck's practice of physician studying out, right? So plan credentialing early, even if you're working for yourself. Let's say right now it's March, I'm graduating soon, or I'm leaving residency. I want to have my practice in September. Here is the plan of what I need to do. Even ChatGPT will help you create a plan. If you want to recheck your plan with me, no problem. But you need to have a plan because we know that credentialing takes time. You don't want to be stuck in 190 days without a contract. So have a plan. Choose the middle, the business model you want to have, the hybrid, the telemedicine, the walk-in, the concierge. All these options are there, right? Learn what insurance company wants from you as a participating provider and as out-of-network provider, right? So which direction you're going to take, learn all the limitations you have with each side. Use a company for credentialing or work with somebody that has experience, right? And monitor everything that's being done for your license. You work very hard to get your license. You're going to work as hard to keep your license because credentialing is one part. There's billing, there's audit, there's too much going on that really creates a liability for you. And it's important to have a monitoring process in place when it comes to running your business operations in medicine. Oh my God, we're almost there. Takeaways, right? Takeaways are the best. So, since we are talking about credentialing and how important it is, right? It's part of our business in medicine. It impacts your revenue, your patient access, your practice growth, your compliance, your business scalability, a lot of things, right? But maybe credentialing is not something you need because you want to be out of network, because you're an esthetician in dermatology and you prefer not to deal with an insurance company because your specialty is better out of network. This is something that takes time to determine, right? You could get into the network and get out in 90 days and you'll be considered out of network by filing a specific request. So there's ways that you can maneuver, understand the insurance company, see if you like the reimbursement, see if you like working with insurance company, and if you don't, you can leave the network in a specific way. There's rules for doing that, right? So again, credentialing is not paperwork; it's a strategic infrastructure, and I believe I'm done. I want to thank everyone for staying with us for a little bit longer than I planned. But this is a very broad topic, a lot to talk about, and everyone is different and unique. Every situation is not the same. So we try to tailor a webinar that is general, but if anyone has any questions, anyone is going through something right now, if you have a pain point that you're dealing with, use the Slack community to communicate with me and we'll get those answers out to you. Thank you so much, everyone, and hopefully we get to hear more and more of one another soon.
Yep. Well, this is a great time to ask questions actually as well here, and
Sure.
there are a couple questions that are there. But before we get to the questions, can I just have a show of hands? How many of you here as attendees are physicians who are physicians? Can I get am I able to? Yes, I see. Okay, great. Yeah, and if you are a prescribing physician, you do have access to that community. I encourage you to log in or just write to us if you have problems. You should log in. It's a single sign-on, so you should be able to log in pretty seamlessly using your Charm Health account, and you can ask your questions there. And before I wrap up here, let's get to our questions. We have some questions that are already there. Um, okay, let's see. I think,
I can see them.
yep, super. Um, all
Do you want me
right.
to read it or you will
Go
read
ahead.
it?
Yeah, yeah, if you're Yeah, go ahead if you'd like to do
Okay.
that. That's fine.
The question came in, what about billing under a different provider who is credentialed with the payer if they're a supervisor role? Very good question. This is dealing with incidental and stock regulations, so you have to be really careful. There are certain limitations, MD to MD. So you won't be able to implement those there. But NP and PA with an MD model that works as supervising. If you don't mind posting that question in our chat in Slack, I can answer in detail, but I would love to know the degree of the supervisor. That will help me manage the answer better. But there are certain regulations which it's in a state level and on the insurance payer level that mandated to follow.
I mean, if any of you really want to speak up and then ask your questions directly, that's also fine. Okay, would you like to go on to the next question? Whoever did give that question, it's an anonymous attendee. Um, if you
Okay.
would like to respond as well,
Okay.
and with the more details. Go ahead, Olga.
Okay, so I am newly established PM HNP with an active license and collaborative agreement in place, and I'm currently waiting for my DEA registration and insurance credentialing to be completed. Oh my God, perfect scenario. My clinic already has a registered LLC. My questions are, can I begin seeing patients on a cash pay basis while waiting for credentialing approval? Yes, you can, as long you are I would prefer that you have your DA so you can prescribe, right? Because you have certain limitations. So what you can, how well you can manage that patient. Um, you will have issues with prescribing to Medicaid patients because the pharmacy will not recognize your enrollment and they will not be able to dispense the medication to them. So I would prefer for you to tell me your Medicaid status on an individual level if you have it. If you don't, make sure to get Medicaid. If you're not seeing Medicaid patients and you're mostly in Medicare, you should be fine. But you can definitely fix your Medicaid, start your credentialing process if you want. While you're going through it, you can charge patients a flat fee. Make sure you have a financial policy in place, which you can buy online, ask your peers, ask ChatGPT to create it. They're very standard. It's a relationship between you and the patient where you are advising them what the care will cost and they agreeing to in writing, no verbal agreements. Everything has to be in writing. In case there's an audit or the patient decides to take action, you have a document in place. Next question was asked, should I operate under my clinic's business name or practice under my individual license until insurance credentialing is finalized? Your clinic's business name is the only used for insurance companies to issue your payment. It's to file taxes. It's not an operating license for anything else. Your license, your individual license that's attached to your NPI is the license you're going to use when you're seeing patients and submitting claims to insurance company. Your business tax ID, your LLC, is to the name the insurance company will issue a check. Okay. Let me just scroll a little bit down. By the way, if you have any questions, Yomi, you're on the call, so let us know. I can uh, answer to you more detail. Then we have Chinese who ask a question. Is that ability to ask more questions later only specifically for physicians or other prescribing providers as well? It's for anyone. It's for anyone that is prescribing now through Charm Health or for anyone that is looking to, have a question. We can have a conversation in Slack community. And we have final question. How many professionals or peer references do we generally need for credentialing for commercial insurances? Are general requirements for these? Thank you. So peer references usually up to 3. If you have a CAQH practice account, you will see that there's 3 positions for peer references. I usually just ask for 1, but if you have someone that you have 3 in advance, that's fine. But typically, you want your 1 best reference to put on the CAQH and to use it down the road with all the credentials that are being done for you. We covered all the questions. Oh, something just came in. Um, we have we have an up and running clinic, but are adding 2 NPs after a train wreck credential experience with the company. I am taking this on myself. Would you recommend starting with Medicaid before moving to other payers? For the maybe it's a family practice. I'm hoping it is. For everything that you do, Medicaid should be your base because Medicaid is needed in order to go into Medicaid HMOs. You also need Medicare depending on your populations, right? If you're seeing geriatric population, you need Medicare and Medicaid, but Medicaid is important. However, for commercial insurances, you can start right away. So Cigna, United, Blue Cross, Aetna, you can start CAQH and you can start submitting applications, right? Make sure they have the board status, the NPs, and that they have enough hours in your state to be considered independent to start credentialing. But definitely start with Medicaid. Check if you need Medicare based on your patient population and start with the commercials. Once you have your Medicaid, you'll be able to take them to the HMOs.
I see that Ashley Mahin, I think, is one of our
Mm.
attendees that have joined the Slack channel as well. So,
Oh, very
Ashley,
nice.
Dr. Ashley, you're welcome to connect with Olga there as well.
Yeah, as she said, it's a family practice. Yeah, so you coming into the role of a primary care PCP role, you want the patients to be able to select the NPs instead of selecting your physician. So they'll have to get through Medicaid credentialing, and then they're directly with each insurance that is under the Medicaid umbrella.
Super. I do see there's another question that's come in.
Hmm. Okay. How do I sign up with Charm Health without credentialing? Um,
I don't,
you'll be
I
able to
don't,
help me with that?
yeah, I don't believe you need to be credentialed in order to sign up.
Correct. It's not associated at all. You can use Charm
So
Health to prescribe. You can use Charm Health for storing your private pay patients. It's a technology platform for documenting clinical side.
perfect. All right.
Okay.
I don't know if there are any other questions, but that Olga, that what a thorough and wonderful presentation. It was so detailed. I did not expect the webinar to go so long, but it is very enjoyable and you went really swiftly through it. I do have another question here. What to do for peer references when I've been in private practice for years, a solo practice?
I think in your case, you will speak to somebody who maybe you are associated with through medical society, or maybe it's your friend who is also the same specialist. You just need to have their name on file and their phone number of the practice, and that's it.
Awesome. So I want to take a moment to thank Olga for a clear, grounded, and genuinely practical session. What stood out here is how she framed credentialing and payer enrollment not just as paperwork, but as as foundational financial drivers of a practice. If you're not properly credentialed and enrolled, you may not even be able to submit claims. And if you start seeing patients before your effective date, you're often not reimbursed at all since most payers won't have backdate contracts. So there's so much information that you gave us. You walked through the real world trade-offs between out-of-network and in-network models, um, and and just so much how timing matters. Getting credentials so your contracts are active when you're open, not months later, can make a difference. So much. And from our perspective as an EHR company, we're not here to promote Elga services, but we do recognize that these decisions directly impact how a practice operates, sustains itself, and grows. If you'd like to continue learning from experts like Olga and from peers navigating similar decisions, please join our Charm Health Square community platform for healthcare professionals. Physicians actively use Charm Health EHR, who use EHR. People are physicians who use Charm Health EHR, who have ERX and EPCS enabled, can access it directly. Other practicing physicians can join through an invitation from an existing member. CH is designed to bring clinicians and partners together for collaboration, shared learning, and practical insights, whether it's credentialing, contracts, or the broader revenue cycle. You can learn more about this at charmhealthsquare.com. Olga, thank you so much for this thoughtful and
Thank you.
actionable
Absolutely.
session. And thank you all for being part of the Charm Health and Charm Health Square community.
And again,
Um,
we'll see each other on Slack if anybody needs anything, any more assistance.
This person is asking, how do I contact you to sign up? And I'm not sure if she's asking about Charm Health or your credentialing services. I believe Olga's information is right there on that last slide. Olga,
Hmm.
if you would just want to say it.
Yeah, you can
Olga.
contact me by email, olgak@wchsb.com. You can do the QR code. It will direct you to my Calendly. We can schedule a talk right away. There's a website. I'm on LinkedIn and I'm on Slack community, so we'll find each other for definitely.
All right, wonderful. And of course, you can sign up for Charm Health at charmhealth.com. So wonderful.
All right.
Thank you so much. I think we got all the questions and I wanted to again thank you, Elga, for your time.
Thank you so much for your time as well.
Okay,
I look forward. Take care. Bye,
take
guys.
care, Elga. Take care. Yeah, bye-bye.